right, so again, this morning we have a pleasure to have Dr. Ming Chen, Professor of Physical Medicine Rehabilitation at the University of Alberta, and you're the Director of, is it the Peripheral Nerve Research Group?
Yeah, it's a clinical research class. Yeah.
Director of the Clinical Research Program. He's published quite a bit in peripheral nerve reconstruction and rehabilitation and so forth. We're very pleased to have you this morning to talk about how activity enhances peripheral nerve regeneration.
Oh, great.
Perfect, thank you.
I don't think I can be a better place to talk about that. Many of you know that well. But well, it really is a great pleasure to be here. As I mentioned, I was here in the 1990s as a fellow for several years. And so yesterday, just going down to Boston Common, it kind of reminded me that the thing we did when my daughter was really young, taking her to look at the swan boat. And in the spring now, you have the magnolia trees flowering, and something that we never get, we're not a million years. So I guess it's wonderful to see it again. So now, do you want me to make sure everybody online can hear me?
Well, I just got a text and they said this is a little better, they can hear now. So,
Okay, that's wonderful.
so Jorge, if you can't hear, send me another text. And again, the microphone is going to be on that machine. There.
I see. Okay. Well, I'll speak louder. If that's a problem, let me know. So the title of my talk, being active and nerve regeneration. I'll go into the details, about that, because that is a bit of a turn of phrase to look at, the different modalities that we have been interested in. And hopefully at the end, they will all make sense when they come together. But before we go there, there are some background details that I would like to lay out just as an introduction. I don't really need to belabor this unnecessarily, except to say that, based on this Sunderland's classification from grade 1 to 5, one of the major issues about nerve injury is when one gets to anything above grade 1, that's a neuroplexia, the outcomes are bad in the sense that the distal stump will go on to degenerate. And so the challenges that comes with that, first of all, is distance that, as you know well, the rate of degeneration, say, a millimeter a day. You have a brachial plexus injury, destined the nerves to go into your hand, 800 millimeters, say, as an average. That process is going to take, over 2 years. And so, nerves really don't hang around forever in terms of being receptive to regenerating nerve axons. And this one is some data from one of my colleagues, Tassagon. Just to say that when nerves have been disconnected to the innervation, the target, we call that chronic insomnia. The condition in distal stump deteriorates very quickly, and as you can see with the regression, the plot there, if the delay of reinnervation in this animal model anything more than 3 months, the chances of the motor axons getting connected with their innervation, the target, become much less, below 50%. So in the human, 3 months really doesn't take us very far. So with that in mind, I'd like to go into an area of work that we have been pursuing for over 10 years. Some examples of what we have done with the treatment technique. And then we'll go into some new directions, second part of my talk. So this term, activity-dependent therapies, it has been around, and I think it is becoming more talked about in different arenas. So in spinal cord injury, for example, with epidural stimulation, But the examples that I want to use today are more specifically on the impact of this group of modalities on peripheral nerve regeneration. So this is just one set of treatment that we have been interested in, post-surgical electrical stimulation, and this method has been around for quite a while, and I'll just try to go back to look at the basis of this before we move on to the clinical translation. So this is a busy slide, so I would just go a bit more slowly from the top to lay out the method that has the use in a rat model with femoral nerve laceration or isotomy, as you can see on the red line of the line. So immediately after the repair, they would stimulate the proximal stump of the femoral nerve, as you can see just right to TTX, continuously 20 hertz an hour. And they wanted to look at the effect of that. So several things that they did. Number one is that they would wait for the nerve to regenerate to the distal stump. So as you can see on the right-hand side, so just to use the muscle end to the quadriceps, what they did after a period of a month or so, they would back label those axons that have regenerated that far, and that you can count the anterior horn cells in the spinal cord with the back labeling. Now, the thing to focus on is the bottom right plot there, is that they had 5 groups of animals. So if you look at the bottom one of the diamond symbols, that was a group of animals that got stimulated continuously for two weeks. So if you use a reference point, look at the black dot now, that's the control group. Is that if you leave them to survive and back label them, if you wait about 8 weeks, their level of regeneration would reach the baseline level, which is the gray horizontal bar there. But it took a long time. Yeah. But if you look at the stimulation 2 weeks group, there really was quite a marked acceleration of regeneration to that point. But what really is much more interesting to the possibility of clinical translation is that what Tesla also did was to progressively reduce the amount of stimulation, so down to 1 week, a day, and an hour with all the open symbols.
Can I ask a question? Well, one thing that I've never been clear on is we only get a frequency. We don't get an amplitude. We don't get a pulse width. We don't get any other information. Are we sure that we depolarizing an axon, or are there any other parameters that are available for what's the secret sauce of what kind of stimulation needs to be applied to the nerve to have these effects?
I mean, and that is a good point. I mean, exactly. I think it reminds me of many papers where, I mean, especially go into high impact methods that actually get squeezed, right? And they assume that it's not obvious. So the pulse width that we generally use about 0.1 millisecond, okay, and 100 microsecond, and the intensity is strong enough that there has to be depolarization, okay, the generation of action potentials, and you can actually watch, the response to the stimulus and use that as a way of titrating the intensity.
And on a severed nerve, how are you seeing a response to the stimulation? The adjacent muscles?
Yeah. Okay. So why don't we just use this as an example here? Is that that's exactly what they did, was they stimulated on the proximal nerve stump. Mm-hmm. That is functional.
Okay.
And so because that is retrograde propagation of the extra potentials, so you can see that. So that's exactly what that line is showing. And if you block it with TTAs,
Okay.
then you get rid of it. And if you let
Got
it wash out, it will come back.
So this is proximal femoral nerves. You're getting some iliopsoas response or something.
No, this is from the nerves. So, it would allow you to judge how much depolarization that you're getting. Now, there are the situations that we can monitor the degree of depolarization. For example, one of the studies that we did is with cubital tunnel syndrome.
Yeah.
So the nerve is actually intact.
Okay.
Yeah. So you can recall from different muscle groups distal to the cubital tunnel to gauge the level activation. But that is really important.
But it sounds like the answer is you want it high enough that you're going to depolarize the axis.
Absolutely.
And that's okay, perfect. Thank
Absolutely.
you.
And if you're looking at the rat, what you see is their muscles will go like this.
Perfect.
Yeah.
Okay.
Yeah. Okay. So but the main point to point out in plot B is to say that if you stimulate just for an hour, the effect is actually the same as it is for 2 weeks. And that's where clinically it becomes far more feasible. And I'll show you, what we did with it. But to look at this plot here is just kind of one of the slides to look at the mechanisms, of this. And there's been a lot of work, but BDNF, brain-derived neurotrophic factor, is a well-known example. And what you can see is that compared to no stimulation on the left, that's not a lot of expression of BDNF. If you stimulate that for 3 hours, you can see the upregulation of the staining, and likewise for an hour. The other thing, Justin, to answer your question about activation, is that when they apply TTX, then that is to abolish the action of propagation. There was no effect.
Okay.
Both rates were identical to the left. So that's another way of saying that why activation is so important. I mean, that really is the whole story.
Perfect.
Yeah. Okay. So now, as I alluded to, we really wanted to look at, do humans behave the same? And so we have done about 4 studies, and these are 2 of the studies that we published. And so this one in neurosurgery is a RCT looking at the severe cubital tunnel syndrome. And so patients we selected, as you can see, the inclusion criteria, people with very severe axonal loss injury, McGowan 3. And they were randomized to the stimulation group of control, again with the 1 hour stimulation, and each of them was followed for 3 years at the annual intervals to look at the physiological return as well as functional outcomes. And that's one example of a patient with severe cubital tunnel on the left. You can see with the wasting of the loss of motor axons, and that was in the beginning. And this is to show clinically how that was done of the ulnar nerve decompressed, and 2 electrodes were inserted proximal to the site of compression and connected to the grass stimulator that has been used in animal studies. We still use that, and with 20 hertz. And in these patients, we actually monitor the degree of depolarization on the EMG machine and titrate that one. And this is that same patient 3 years later at the end. As you can see that the atrophy has largely disappeared. And when we look at the physiological outcomes using the motor unit number estimation as a yardstick, as you can see, say, for example, the stimulation group followed the patients for 3 years compared to baseline with the gray bar. There was substantial reinnervation in the hypothenar muscles. Certainly at 3 years, but even starting from year, whereas the control group not nearly. So you can.
Let me ask another question on that. On the animal study, we saw this early peak of many axons, but then the lines merged by about 6 to 8 weeks.
Yes.
There was not a long-term competitive advantage, but in the clinical studies are showing that there's definitely a long-term competitive advantage.
So that's a very good question. Two points about that. Number one is that the animal outcome looking at back labeling is only a small distance away on the peroneal nerve. It's not actually a motor unit count on the muscle. So that distance, especially in rats, they regenerate much more effectively than the human. And it was such a short distance. That's why they caught up.
Got it. Okay.
Number two is that the distance that we're talking about, so we're not talking about within a month with that distance. We're talking about at least a year before we started seeing there's something. And they continue. So the challenge then, when you multiply that distance, become much more formidable. So the two measures are quite different. I think that's the right way to explain that. But functionally, what we did here is to look at key pinch, so we look at adductor pollicus and first also interosseous. And you can see that the change in pinch strength, the differences are similar to the physiological measure, that it was much more so in the stimulated group compared to the control.
And again, this is all the only intervention here is a single hour at the time of surgery.
Only one
and
hour.
the effect is still going on 3 years later.
And I will go into a little bit about that, but that is a very good point. So in Tassa's study, for example, they stimulated for 2 weeks, similar. And so that actually has been looked at, is how long is long enough and is more better. The answer to that is there seems to be a sweet spot for motor fibers. They're fairly forgiving. If you stimulate them longer, repeated stimulating them, they will do the same. They don't really get any better, but they don't get worse. However, for sensory nerves, the story is totally different. Is that you stimulate the sensory nerves any more than 3 hours, they actually get worse after that. So the sweet spot
in the sensory regeneration is inhibited.
It's getting inhibited. Exactly. Yes. And I would go into details if you're interested, but mechanistically, sensory nerves are very different from motor nerves. And so thinking axonal regeneration as a homogeneous entity is actually dangerous, I think, because the way that they need to be handled and the molecular mechanisms, they are really different. I mean, even down to the swan cell levels. Motor swan cells are not the same.
Yeah.
Okay. So this is the other question that we wanted to answer is, what about sensory fibers? As I mentioned, is can we assume? And we couldn't do that. We needed to have a different study, and in this case, we look at the patients with the digital nerve laceration, and the paradigm is the same: repairing it, and then stimulated for an hour, and then we pull the wire out, and that's the end. And to look at the physiological and functional outcomes, we use 2-point discrimination on the filaments to look at large myelinated fibers, and then we use quantitative sensory testing, different modalities that you can see there for the smaller fibers and C fibers, and then functionally we use the disability arms, shoulder, and hand question. So these patients were randomized and followed for 6 weeks, for 6 months. So I just used the top left plot with static 2-point discrimination. This illustration is that during the follow-up, you can see they all started out as 1, which is the level of sensitivity at baseline. And then as the number gets less, they improve. That's basically what that means.
This is again ulnar nerve patients.
Digital nerves. And so
I'm sorry, digital nerves. Yes, right.
Or ulnar. So any one of the digits. And so you compare the trends with the solid dots with the control group. You can see the stimulated group, they did significantly better, certainly by 6 months, but as far back as 3 to 4 months. So that's the same trend applies to Sims-Weinstein monofilament with pressure sensation, top right. The middle row with cold detection, the threshold, warm detection, the thresholds, the same trend. And then looking at DASH with the disability subscale and the work subscale, there was a significant difference in the functional outcomes as well. So it seems that with an hour of stimulation for sensory fibers, they're fine. And so I will move on at this point to look at what other modalities there are that might be worth thinking about. That answers some of your questions as well, Justin. So before we go there, just looking at the mechanistic aspect of post-surgical electrical stimulation, is this phenomenon called staggered regeneration that is shown at the top panel there. And you can see that at the site of injury, nerves, as they start out regenerating, they're often the delays, misdirection tubes. So the bottom axon there did a little loop, and it found its way down the right direction quite quickly. But the middle one, there was a little bit more delay, and the top one, just to signify that their axons are so misdirected that it went completely the opposite direction and never had a chance to go anywhere. And that's what the post-surgical electrical stimulation is to reduce it. So that has been shown in a number of different labs. But when they measure the extension rate in the distal stump, there was actually no difference. So really what the delay is that you make them go faster in the right direction, then the more of them will reach target. Now, with that in mind, can we do that? And so this is something that we have thought about for quite a while, and very interested in conditioning lesion, because this is something that was described 40 years ago, has been repeated in many labs around the world. They all found the same thing, is that it works really well. So the paradigm, but here, as you can see, if we are planning a nerve transfer procedure a week ahead of time, if you induce an artificial injury to the nerve stump, what that does is that it starts priming the nerve through this calcium wave, as you can see, the injury potential, and that gets back propagated to the neuronal body and triggers a whole slew of regenerative pathways, including BDNF, as you can see up at the top, and that in turn would trickle down towards the nucleus for transcription and translation. So by the time when the nerve repair happens, the cell ball is ready. It's primed to go. So the structural protein down at the bottom here is manufactured, packaged, and once when the highway is restored, the anti-gray transport will take them there. Now, despite 40 years of work on this, it has never been used clinically for a good number of reasons. And I think probably one of the most difficult one to get around is to say to a patient, well, we want to cut your nerve, believing that likely you would do better. I mean, nobody, I think, would be brave enough to say that for sure. And so our goal is to find a non-injurious method that would approximate the effect of actually cutting someone's nerve and get the conditioning effect from that. And there was a couple of papers that was published quite a number of years back, and nobody actually followed up on it, suggesting that if you electrically stimulate the nerve ahead of time, a week ahead of time, it actually would impart an effect that is somewhat similar, but was never really fully studied. So this is where we came in. So in this paper in 2018, with Christine de Weber on the left, and Janet Singer, past president, doing PhD with us. So what we did is to compare those groups, both the traditional paradigm of conditioning lesion, and then we stimulate the nerve for an hour, 7 days ahead of time. That's conditioning electrical stimulation compared to sham. So what I'd like to draw your attention to is on the right-hand side with the distance of regeneration that you can see it along the dotted line on the left in panel A, for example, that's where the nerve injury was. And then we follow out the animal for a month or so, and we look at the distance of the regeneration in the distal stump. As you can see in the bottom panel figure there, you can see with filament 2000 NF200, sorry, is NF200, this antibody. You can see the axon label. And so we look at the distance, so you can see with the conditioning lesion in red there, right where the solid line is where 80% of the axons have regenerated to that distance. That's how we define the front of it. The one that you can't see about that is the electrical stimulation group in A. The distance is very similar, and if you compare those to the bottom two groups with sham or no stimulation electro, this difference is obvious. But if you look at the whole groups of animals at the bottom with the blue and red line, you can see that for the same distance, the numbers of axons are far greater. So you can see it difference between the control groups and the stimulation lesion. But the distance that they grew off is far greater as well, and 2.5 times, somewhere around there. And then looking at some of the mechanisms, GAP43 or growth-associated protein 43, and looking at expression, the amount of expression in the electrical stimulation group and the conditioning lesion group are very similar, and they are significantly greater than in the control. So, this is one method that we are interested in, because unlike post-surgical stimulation, the difference in timing is that in the case of post-surgery, you're looking at the staggered regeneration, whereas in the conditioning, you're looking at actually accelerating the growth in the distal stump. So the idea is, what if you use them both? Right. So, but I won't get to that because we haven't done it. So I really okay. But I want to switch here because I think this is yet another method of looking at activity dependence. And I think exercise is something that, especially in the rehab hospital, we talk about all the time. The question that here is, in what context that exercise is good for. So Art English is in Emory. He is the one who have done a lot of this work early on, and so there's quite a bit of animal literature on it. But again, no human literature as yet, and that is something that we're kind of moving ahead with. But so just to show that we have big gyms here, as in or the rehab hospital, but the reasons that we do this, that exercise has major systemic effects on things such as cardiovascular, blood sugar control, muscle mass and strength. But really, I think what we want to ask in this case is not just about any kind of exercise, but what kind of exercise is needed specifically for peripheral nerve regeneration. So the top three groups with prevention of contractures, for example, and retraining of movement patterns, those are things that what exercise is being done for, a lot of the time. And certainly, I think in the spinal cord literature now, with the epidural stimulation, it seems like the effect of that on neuroplasticity is tremendous. But let's focus at the bottom. That's the purpose of my dissertation here. So in the animal models, we look at the combination of conditioning electrical stimulation, the second one from the top, and then the third one is for exercise training. So these animals, they were put through a short program of 4 weeks of training or 12 weeks of training. But before that, the electrical stimulation group would get stimulation to the tibial nerve before the transfer to the fibular nerve a week ahead of time. And then that's the fourth group that combine electrical stimulation and exercise training. And so this is based on Arthur English training protocol of 1 hour per day at 10 meters per minute. So that kind of corresponds to about moderate speed of walking for a person on a treadmill. 5 days a week, say, as I said, either short duration for 4 weeks or long duration for 3 months. So the results, some of the results are here. So again, looking at the distance of regeneration in the distal stump, you can see that with both conditioning, electrical stimulation, and training, there was a significant increase in the length compared to the top, which is distal nerve transfer alone. But there's actually a synergistic effect when you put exercise and electrical stimulation together. And this is looking at the muscle reinnervation and just using the muscle mass as a surrogate measure, of that. So again, let's focus on the short training group here. So when you look at the increase, is that with exercise and electrical stimulation compared to control, there was a significant difference. There was an improvement, but that's not significant. It's with each modality individually. But when you combine the two of them, then they became much more effective. And the trend is very similar to this exercise for 12 weeks. So that means a 4 weeks of exercise regime has beneficial effect as instead of going any longer than that. And this is looking at the functional outcome. So this is the gait cycle looking at the kinematics of joint movements. So just again, focusing on the left-hand plot here, that during the gait cycle with swing phase and then the dorsal and the stand phase. So you can see that in the normal group during swing phase, obviously that's the dorsiflexion movement there, and then it picked up during so you get pushed down during stance phase. So using that as a reference line, as you can see then, is that in the nerve transfer group that is in green, they had foot drop, during the follow-up assessments. And it is the red line, which is the combination of the electrical stimulation and exercise, that most closely approximated the healthy control with the individual modalities of electrical stimulation exercise in between. So we have, in this study then, we looked at the distance of regeneration in the This those done, we look at the reinnervation in the muscle, and we look at the functional outcomes in walking. Now, this is something that I was quite surprised by. It's probably because of my naiveness of not really thinking too much about it. Is that nerve injury has a tremendous impact on bone mass, and so this is the tibia, and you can see the trajectory here. So on the left side, so medial aspect is part of the tibia innervated by the tibial nerve. Now, in this animal, it was the fibular nerve that was cut. So on the lateral part of it is innervated by the tibial nerve. And there is a tremendous loss of tuberculin in the nerve. After exercise and with exercise, after nerve repair, is that although it is not back to normal, but certainly has a tremendous amount of restoration. And so I think this is something to bear in mind. I don't know from your experience where you've come across many of your patients, but in some of ours, after nerve repair, they seemingly reinnervated the biceps, they're fine. And then, in Edmonton, it's easy to born in the winter. Then they have a fracture of the humerus, and they're back up to square one. So with that, I would just summarize this just to make sure that we have time to discuss some of the details. So with this presentation, the four major points that I would like to highlight. The first one is that nerve activation, and there are many different ways of doing that, but I think collectively that is an important group of modalities to consider. That I think they do have an important role to play for regeneration, but the exact way of doing it probably is different. Number two is that by combining different modalities, I think that's a possibility that you might get the best of both worlds, depending on the mechanism of actions. And there are two clinical studies that's really to point out the clinical feasibility of these methods. That electrical stimulation has been used in clinical medicine for millennia, and so that's really no stranger to us. But I think that the bottom point here is the major one, is that the mechanistic understanding, I think, is absolutely crucial in terms of how we can rationally determine what modalities are likely synergistic and might be combined. Now, I just want to summarize this. I have some more details, but I thought instead of getting bogged down in the minutiae, is that I will leave it until later when we're chatting about this, then I can show you some of the thoughts that we have. But before we move there, I just want to show you our team in Edmonton. So I certainly like your group. This is a multidisciplinary endeavor. You can see some of the surgeons, graduate students, rehab specialists, OT and PT. And then we have research labs that are built into the program deliberately. And Christine Weber is one of the collaborators. So many of the animal studies that I presented is from her lab. And so these are the people. And then other collaborators outside of University of Alberta, like Tessa Gorn, who is now in Toronto, and Valerie Verge and in Saskatoon, and Raj Meter, who's also a neurosurgeon, he's in Calgary. And the funding agencies, especially the Canadian Institutes of Health Research, has been supporting us for over a decade. So with that, I'd like to say thank you and be happy to discuss further and answer questions.
Thank you. I think that last piece speaks a lot to rehabilitation strategy. And I'd be interested in how you've incorporated that. So one of the things I think about when I looked at that activity is it the activity specific to the limb that has a nerve injury? Are you driving that motor neuron pool and that's encouraging them to grow? And I would imagine so, because I think of the phrenic nerve transfers. You know, the phrenic nerve, the brainstem is pulsing it all day long and they grow beautifully. I don't use them very often. When you do, you get this 1 millimeter nerve and you put it into, you know, one of the divisions of the upper trunk. Next thing you know, it fills in the pectoralis and it fills in the biceps. And it seems to be a much more robust nerve transfer. I always thought it's probably because they was being driven. You know, which is kind of the basis of what we ask in therapy is to drive the source of the nerve transfer. Is that it changed how you all do therapy for nerve transfer patients?
So I think what you're pointing to is the specificity
Yes.
of exercise or other activation. And I think that is a very important consideration because, you know, if you truly want to accelerate growth in this nerve here to your bicep, your oberlin, I think you should really be doing this. Because if you did that, or you just, you know, you do your treadmill. I think the molecular environment that stems from the result of activation in around the motor neuron pool, for example, that's what you're interested in, is really important. Yeah, because if the motor neuron pool get activated in the lumbar spine, I think it's many miles.
Yeah. In a dosing for that. I mean, in the rats, you're doing like 8,600 steps or whatever for a patient. Can you imagine we want him squeezing that ball all day long for that oberlin? Do we think an hour a day is good? If you
Well, I mean, that's really is the limitation, isn't it? When one transfers animal studies to the human or to different limbs. I mean, even with the 8,000 steps in the rat, would it necessarily do the same in the human? We really don't know that. Yeah. And so that's why that translation is really important. So, yes, I think the dose, the intensity, all those things really need to be quantified. And my thinking is we're in the beginning of this. And I think, you know, to do it properly, I mean, all those parameters, I think they need to be compared and quantified. Absolutely. Yeah.
And one thing I didn't catch is the conditioning electrical stimulation versus the brief electrical stimulation at the time of surgery.
Yes.
Were the effects essentially the same? It's sort of you could do it at the time of surgery, you could do it earlier than surgery, but the ultimate effect is you've got better regeneration. Were they the same effects?
Yeah. So let's see whether I have that slide. Because I didn't want to get bogged down too much by initiate, but let's see when we have it. But there you go. Yeah. Okay.
So explain this again.
Yeah. So in this study, we actually look at the electrical stimulation, but one is with the conditioning paradigm, and the other one is the pulse.
Yep.
Yeah. So, you know, we are kind of putting them head to head of what the differences are. So we have, again, the different groups. First one here with conditioning electrical stimulation, and then the post-surgical electrical stimulation, PES, and then the naive. Okay. So with this in mind, then, with the rat tibial nerve repair, what we found is that when we look at the length of regeneration at distal stump, the blue line is conditioning electrical stimulation, the green line is the control naive, and the red line is the post-surgical electrical stimulation.
Got it. Okay.
So you see
there was a distinct advantage to doing it before.
Okay. Exactly. Yeah, exactly.
And then were they combined? Did I miss that? Did you ever do both? And
we did, but I need to bring it down to show you. But let me finish showing you this.
Okay.
So in this study, we look at behavioral outcomes. On the motor side, in C, you have the horizontal ladder. So with the tibial nerve repaired, the foot placement becomes better. So they would manage to get the foot onto the rung without falling off. So as you can see, the higher the number, the better. So in the conditioning group in the, blue is significantly better than the green. And then the post-electrical, the group improved, but it was not significant.
Interesting.
And then you look at the toe spread in D. So with the tibial nerve innervating the intrinsic foot muscle as they recover the ability to abduct the toe, so they become wider. So that's the distance. So as you can see, the distance is wider in the conditioning group compared to the control, and the post-surgical electrical stimulation group did catch up, but it's much later. And then looking at the sensory outcomes, the differences are the same. When we look at the PG 9.5 versus sustained for a skin cutaneous innervation, you can see in B, it is higher with the conditioning group. And then when we look at the behavior for pressure sensitivity, the gauge of monofilaments that the rats were sensitive to, as you can see at the bottom, the green line is that they could sense much smaller gauge filaments than the other two groups.
For the post-op ESIM, was it immediately after surgery or during the training process?
It's immediately after.
Okay.
Yeah, at the time of nerve graft repair.
What are your thoughts on ESIM during training?
Yeah,
So that's a big question.
Yeah, so that's a good point, and that's where the interest of, if we stimulate them a longer period of time, we repeated the bowels stimulation, and the answer is actually quite striking. Is it works for sensory, but not for motor. Motor is forgiving, so it really depends on.
But nobody did better. Sensory worse, motor equivalent, sounds like.
Yeah. So if you look at the literature as a whole, depending on who you ask, some would say is the same, some would say is better, and some would say is worse. Yeah. So to give you an example is, in the Chicago group that they really published a very nicely done paper with John Rogers. And they decided a biodegradable stimulator that's implanted. And they did the stimulation over a week. And they did it several hours a day. And they showed that if you did it for a week, it's better. However, if you look at the actual magnitude of difference, very small. And but if you talk to some other groups like in Taiwan, where they use the surface stimulation, they said, really you don't need to do it any more than half an hour. Because nobody likes to be stimulated on the surface continuously.
Right.
Yeah. I mean, it's really uncomfortable.
Yeah.
I think the average, if you look at the meta-analysis, is an hour to 3 hours probably where the sweet spot is. Mm-hmm. And when you do a lot more than that, you really don't add much of anything. And that's on the motor side. On the sensory side, I think it is really clear that they do worse. And one of the reasons, in fact, there might be a graph that's worth showing you later on, is BDNFs and sensory nerve fibers, their interaction is not necessarily linear. The more BDNF that you have, actually, that is the sweet spot. That if you go past the sweet spot, they actually becomes a big problem. So that's why BDNF is such a major molecule in the neuropathic pain pathway. You give lots of it, I mean, the nerves are really aren't happy. So I think the trick is where you set that spot to, make the most of the upregulation without overdoing.
And your original discussion of the goal is depolarize these axons.
Yes.
Simplifies the whole concept to me, because a lot of people have opinions about how you apply it. You have to put it directly on the nerve, or you can't do it transcutaneously. And I'm imagining the people who've had failed results transcutaneously because they're not turning it up high enough to get full depolarization. So I would imagine, based on what you're showing, that I could do my Oberlin patient transcutaneously, activate the heck out of him with neuromuscular stimulation, 2 weeks in advance, and potentially translate this to the clinic. Has that been looked at?
Yes. So that is a really good point, because practically, those questions in terms of clinical implementations, how you do it is extremely important. So with the particular example that you raised with the Oberlins, doing it in a conditioning fashion, is that we've been doing it, but instead of using it transcutaneously, percutaneously with a surface stimulator, we use a monopolar.
You insert the needle in the
Yes.
ultrasound?
Well, I don't need to do that because, in terms of needle nerve stimulation,
You go tones.
you can do EMG on it. So what
Okay.
you do is instead of using a surface stimulator, you put the electrodes on the muscle, you put the needle in through the skin. Two things that you will notice right away. Number one, the intensity you need to get a compound muscle action potential goes much lower, so that there's much less discomfort.
Yeah.
And number two, when you start moving it, as you get closer and closer with the same intensity, it gets bigger and bigger.
Yeah.
Until you get right on the nerve, then it doesn't go anymore. And then we fix it.
Okay.
Yeah. So that is one easy way to do it. And the Scandinavians being this for 15 years. That's how they did all the nerve conduction study, nerve needles. Now you can use an ultrasound. You can help you place the needle as well. So that's another way to do it.
And so you're already doing this study now?
Yes.
Okay.
Yes. Yeah. So I can stay here for days and tell you about the other ones, but I think this is really just to bring up the broader conversation. So, not necessarily what we are doing, but really it's the concept as a whole. Because I think that's really lots to be gained, and especially in the exercise. Yeah. Because, it's really hard to imagine that 1 hour exercise will do everything for you. I think that is wishful thinking. And do you mind if I jump to that slide?
Oh, please.
Yeah, okay. There we go. So in terms of exercise and other forms of activation, the traditional thinking is that muscles and bones passive recipients of the innervating the nerve. So, the nerve would drive muscle contraction. And when the muscle becomes innervated, it becomes atrophic until it gets reinnervated. But we really don't think that's the case. And so the way that, just to articulate our thinking is that we think that is a much more bidirectional relationship to those that target the tissues in both the case of muscle and bone, that they actually have important feedback pathways that actually would help to direct nerve regeneration and reinnervation. And I think really to tease out that relationship, I think would likely add substantially in a sense of how can you maximize the communication in one direction, but also provide enough feedback. I would again, one can talk about the details of those molecules, but that really is just an illustration of some of the pathways that we're interested in that allows that conversation to go in both directions.
Yeah. I forgot because you're saying that exercise is so helpful. But how much do you think is on the muscular side, and how much is really on the intrinsic changes in nerve repair or in nerve structure changes? Because when you do training, of course, the muscles get stronger, the gait parameters can change, and all the things can change much more than nerve was changing in this instance.
Exactly. I mean, that really is my point, is that with the electrical stimulation that we do, we talk to the nerves directly. But we don't even talk to the distal side of the nerve, we talk to the proximal up to the cell body. And that really would do very little to the muscles, where exercise would.
Except it's not going to do anything to the denervated muscle.
No,
To the neighboring
No,
muscle.
but the muscle, when the muscle gets trained or gets exercised, that the parameters that you have shown us, that the gait parameters are changing. This could be just because of the exercise of the animal, not that the nerve repair was better. Yeah.
So when you look at the gait cycle and the change of the kinematics. Yeah. So the thing is that, exercise per se, would have an effect on the animal's head movement pattern. If not anything else with the plasticity. But I think
But this is then also centrally. do you think that this has an effect directly on the peripheral nerve? So because I see it in this thing two sides. One side is the muscle, one side is the central nervous system, and in between we have the peripheral nerve. So when you do exercise, that the peripheral nerve repair gets better. So is it really the side in the middle, or is it on both sides on the end?
Yeah. So that's a very good question. See what I can tease that out a little bit. So the thing about the data that I showed you in terms of the behavioral change with the gait pattern and the foot drop is that exercise per se had effect in improving the walking and less foot drop, but not nearly as much if you combine the conditioning, electrical stimulation, and exercise. That really improve the level tremendously. So what it means is that with electrical stimulation alone, with nerve regeneration, exercise on the muscles, say, if it nothing to the nerve regeneration, they both have a partial effect, but not until you combine the two that you really get a much bigger effect out of it. I don't think that really fully answers the question. Is exercise really just on the muscle, nothing to do with the nerve growth? Now, the other piece of information that might address is look at the length of regeneration. Is that when we did back, NF200 labeling with antibodies, you can actually see the exercise group, they go much further compared to control without exercise. Because that is the other aspect that talks to the nerve.
In one more aspect on the exercise, I guess I was originally conceptualizing this as exercise driving the core because it's a denervated muscle, but the exercise timing is all through the reinnervation process. So we could be strengthening axons that have arrived in the muscle and adding training to this so they're going to get the best out of whatever does arrive with the exercise. Is that not correct?
Yeah, so, I think to think of exercise being the single mode of talking to the denervated muscle, I don't think it's rational. Is that when we're exercising, if that muscle is not innervated, we'll use all the other muscles around it to make the move.
So you're driving the spinal cord at that point.
You could.
But during your training, you're in the midst of recovery. So that muscle now has received some axons.
Early on, it might not, until later on when the regenerating muscles have reinnervated.
Right. And then the question is, if you timed your exercise only during that period where we know no axons have arrived at the muscle, you get the same effect. Or if you do when you know it has arrived at the muscle, is it a different effect?
Yeah. That's a very good point. So, yeah, I mean, that's one way to address that issue is if that muscle is innervated, it's not participating in all any exercise, would it have a beneficial impact?
I wonder though, is there just general effects of exercise, just moderate to vigorous exercise of just the cardiovascular system, the healing system?
Certainly there's got to be systematic trophic effects from it.
If you look at for example, patients who've had chronic stroke for exercise, the research is just doing moderate to vigorous exercise in general shows better effects on gait, and it's not necessarily the specific modality of exercise, it's just the intensity.
Yeah, I think that always goes back to that issue of specificity versus generalizability.
Right.
But I think the beauty of exercise is I think it would be wrong to go too far one way or the other here. Mm-hmm. I still think if the injury is in the arm, doing arm exercise is better.
Right.
Yeah. Yes.
And we can stop the recording. It'd be great if you could speculate wildly here. On the mechanism side, yeah,
we'll edit this up.
on the mechanism side, I still have a very tough time reconciling all of the kind of proposed hypotheses for why each part works on the sensory or motor fiber side. If it's essentially a preconditioning calcium wave retrograde on the sensory side, and you do this for an hour and continually are sending signals back, would you have the same effect if you just cut the nerve, wait an hour, cut the nerve again, at a retrograde calcium signal an hour later, and then watch the sensory neurite output? Because most of the regeneration slides it seems like you're looking at NF200 and you're looking at the sensory kind of regenerative front. Is that kind of the way on that side? And then on the motor side, sorry to kind of split the two camps, but I don't understand the alignment effect. The field is across the nerve and you're getting a retrograde action potential measured more proximally. So what is the alignment effect happening at the zone of injury for the axons to get to the distance now?
When you say alignment effect, you're talking about the reduction of staggered regeneration you're talking about?
Well, that you're having less disorganized.
Yeah, so reduction of staggered regeneration.
Yeah.
You're saying what accounts for that?
Yeah, I don't understand that.
Okay. That's a rather long question.
Yeah.
The thing about the sensory versus motor, whether you necessarily need to stimulate that versus you cut the nerve and then an hour later you repair.
Yeah. And I guess what do you think explains the mechanism on both nerve ends? If it's like a continued injury and at a certain point, enough injury signals on the sensory side are not beneficial, like at a 3-hour degree of stimulation on the sensory side, that's not helpful. Why on the motor side is the continued stimulation essentially not inhibitory?
Okay. So I think maybe one way to answer your question is that when you stimulate the nerve or when you cut the nerve, you have the calcium wave in terms of the heart injury with injury potential. In terms of the electrical stimulation, you have those action potential voids that will get retrograde propagated to the cell body to activate the machinery. The question then is that if it was DRG for sensory versus the anterior horn cell for motor, why would they respond differently to the same stimuli?
Yeah,
Okay,
that's what I'm curious about.
yeah. So let me say this. Or in the case of the conditioning lesion, when you cut the nerve, we have the injury potential and the calcium wave, but we are not necessarily implying that wave will go on forever, whether it's in the sensory or motor, because that is a very acute influx and they die down, even if you don't repair. So there's no saying that it needs to repair first and then the injury potential will stop. It doesn't work that way. Now, the electrical stimulation is artificial. I mean, the nerve didn't know that whether it's injury, just getting activated. What I think is important to say is that in that case, because you're controlling the duration, then you can make it go on forever too. Now, if you look at the expression BDNF, for example, then you can track of how long that BDNF upregulation is sustained for. And with the inside rehabilitation work, it really is clear that if you keep that up for a long time, it's bad for the cell, you'll kill it. So I hope those two paradigms are not one and the same. Cutting it, injury potential is very brief. Stimulating it, you can do it whatever length you want. So, So, I think we're looking at a conditioning lesion-like effect with stimulation, but with that artificial manipulation, I think we need to be cognizant that you dial in whatever you want for however long you want. I think probably to fully answer that, you need to look at some of the mechanistic data, with the electrical stimulation to look at the kind of effect of very long stimulation. And there are papers on.
And do you think the effect is more mediated by the actual neuron cell bodies and the signals that they're receiving, or do you think that there's a glial effect? Like if you are stimulating a bunch of
we got patient in rooms waiting
Yeah.
for us now. So we got,
that's the whole thing, right? You were saying, you brought up the great point earlier, which is the motor swan cells. You're blasting them. Are they releasing a better, basically, growth factor in lieu for them to?
Yeah, that's a perfect question. I think you hit the nail on the head. Is that I think it's absolutely wrong to say that we are only conditioning the axon, because the interaction between the swan cells, whether they're ensheathing or not, they talk to the axon all the time. So many of this pathway go through one cell. So that is a really important consideration is, to look at molecular pathways that is swan cells is specific and look at how that interaction would either enhance or make no difference. But yeah, no, I think if you look at someone with GBS, he did the same thing on us, especially as you get a lot of things in return.
Yeah, because some of the timescales.
You gotta go, we got patients through here. Are you sticking around for a while?
Yes.
Yeah, we're gonna give it a little.
I know.
We'll circle back. Thank you very much.